do my usual short introduction. So welcome everybody, wherever you are in the world, to another question and answer session with our CEO and host today, Collette Thain. And we're delighted today to welcome Dr. Alan Bonder from Boston in the US. So I hope you have an informative and interesting session, and I will catch up with you later on in the proceedings. Thank you. Enjoy.
Thanks, Alan.
Thank you, Alan.
Welcome to you, Alan, Dr. Bonder, and thank you so much. It's lovely to get overseas visitors to coming here. But you understand there'll be people in today from all around the world. We've got Jean saying hello, everyone. Good to see you, and Eugene. So, Alan, as we discussed this last week, we spoke about you said you're from Boston. Before we start, would you, for those that haven't really seen you on screen before, do you want to say a bit about yourself, Alan, please?
Sure. So thank you, Collette. Again, thanks for the invitation. Again, it's a pleasure to be with you again, even in different parts of the world. But yeah, so I'm Alan Bonder. I am a physician. I'm a hepatologist. I work in Boston at Beth Israel Deaconess Medical Center. I am in charge of the the director of the liver transplant program at the hospital. And I've been in Boston for close to 18 years. I do research in PBC, and I've had an interest in PBC since I actually came to residency. So, and I met Collette and Rob in the past, like a few months ago, I'll say last year, and then we've been in touch since then. So I'm delighted to be here, and then hope I can answer some questions from everyone.
Oh, thank you. Your name has come up a couple of times. I was chatting with Cynthia Levy a few weeks back, and various pharma companies interested in the itch. So it was really nice to know, it was lovely that I could connect it all up. Okay, everybody. Right. So we've got Chris here. Hello, PBT. Chris is here. Thank you for joining us today. It's great to have you here. There, yeah, this is Chris's own welcome. This is our new Head of Education and Development. And Jean, thank you, Dr. Bond, for sharing your notes to help us live a good quality of life with PBC. Isn't that lovely? And it is down to quality of life. Our 25-year anniversary is next month, and I was doing some live film with the States yesterday online, and I was talking to a room full of researchers, and I was explaining how important it is to us and the quality of our lives to know that there's people out there actually rooting for us behind the scenes in the labs and everything else, asking the questions because we hold the answers. So it's exciting. It's great. So I'm going to my first question. I'm going to read, Alan has these questions where I'm going to try and reduce it down, but so as everybody knows what I'm talking about, I'll be brief with this. And a lady was diagnosed with PBC. She said stage 1 in 2014. Not everybody uses these stages. She is now 48. She's on Urso, and it's reduced her liver numbers over the years. She went for a checkup with her hepatologist. The alcohols was elevated at 160, and ALP, AST were also elevated. She's very worried, which is absolutely, I can understand that. So hopefully we can make you feel a bit better today. There's her result of her FibroScan value was 16.2, which she feels extremely high. Doctors recommended a liver biopsy. Her last biopsy was in 2014. I'm not sure why they would have given me one in 2014, because you don't biopsy to diagnose patients unless you're one of the minute number of people who don't have the AME antibody. Anyway, this lady, gentleman, I'm freaking out. Does anyone have any insight or input on what is going on? We need to make this person feel better, Alan, don't we? This is very alarming to her and him, which I can understand.
So I think the first thing to understand, I think as you mentioned, that's actually a very correct statement. Again, I would just, I don't know what was the indication for a liver biopsy in 2014. So again, based on the guidelines from the American Society, even the European Society, if you do have a positive anti-mitochondrial antibody on top of an elevated alkaline phosphatase, you don't need a liver biopsy based on a study of Kate Linder a few years ago. So we actually treat those people with Urso. We do a FibroScan at the beginning of treatment just to actually stage of fibrosis. I think you mentioned the stage of fibrosis. So I think stage of fibrosis go from 0, which means nothing, to 4, which means cirrhosis. In the case of PBC, the FibroScans, a normal FibroScan goes with 3 to 5, that's stage 0 to 1. And then actually 17 is a magic number that we call to diagnose someone with cirrhosis. In the case of, in her case, with the alk phos of 160, I do wonder if there is something else different going on. And I would say it's not a bad idea to get a liver biopsy. And the reason why is PBC comes with other autoimmune conditions. She can have autoimmune hepatitis based on elevation of the ALT, as you mentioned, Collette. So I think in her case it is actually a very good indication to find out what's going on with the liver. But what we know in PBC is the lower the alk phos, the less chances of you progressing in the stage of fibrosis. And her alk phos is not very high, which makes me think might be other things happening. And then again, we mentioned it's called the overlap syndrome. So that you can have the presence of PBC, but you can have an overlap with autoimmune hepatitis or primary sclerosing cholangitis. So actually both of them can interact and have, problems with the stage of fibrosis within the liver. So again, it's not a bad idea. And I would actually encourage her to see what we can treat if she does have an autoimmune component of her liver disease.
That's actually hugely reassuring. So there you are, whoever asked that question. Feel free to give us a ring if you want more information. We can come back again and ask more questions, or you can put them in here today. But so there you are. So he quite endorses another liver biopsy. But really good news that he doesn't think your ALP is particularly high. So that is major, and actually that's a big thing. So please be reassured, don't panic, and let's keep asking questions. Thank you, Anne. And something I'm new here. Well, I can remember how that felt. I was diagnosed with PBC in November last year, which is not a long time really, and she's on 1,000 milligrams of Urso. Main symptoms have been pain in the liver area and fatigue. I've also had a strange weakness in my arms and at times. More recently, I've been getting itching and patches of skin become rough and sore, such as on the side of my neck. For 11 years, I've had similar issue on my left foot. That's been diagnosed as pustular psoriasis and later a fungal infection. Given psoriasis is autoimmune, I'm wondering if I've had autoimmune processes going on in my body for quite some time. And I'm wondering what people have found helpful for skin. Well, so I'll come to the second part of the question in a second. So really, with this psoriasis, she's wondering if she had an autoimmune process going in her body for some time. Alan, what would you say to her?
So first of all, I think, the first part of the question, Collette, is like, can she have autoimmune? She has an autoimmune condition. She's unfortunately more at risk of having more autoimmune conditions. We really don't know what are the keys. So we know that there is, we have predisposing genetics to have an autoimmune condition. We really don't know what is the key to open that door. So sometimes what happens is a viral infection. Sometimes there's a medication that will trigger autoimmunity. So we really don't know. The next part of the question is, for a skin perspective, I think the dryness of the skin is a very common condition in PBC, but also we have to make sure that we rule out other autoimmune conditions linked to PBC, specifically the thyroid. Low thyroid goes very well with PBC. So up to 30% of people with PBC have low thyroid disease. So I would just recommend checking that. And finally, we would recommend for the itching, we start with creams and we go up in a scale of treatments. We start from, UDCA to cholestyramine, and we have really potent medications, even the new medications that are in the clinical trials, that will help people with itching, specifically the fibrates. So again, we do have a great, I would say, amount of options right now to treat those patients to make their life better.
Okay, right. So Sheila's doing a bit of research, but Alan's absolutely right. Many people see PBC have other autoimmune conditions, so make sure they check you for that. But you mentioned doing a gluten-free diet, which has helped your headaches. Fantastic, that's great. If you come in our live 4 o'clock sessions on a Monday and Wednesday, there's people that come in and they tell us how their itching has stopped because of diet. And I'm a great fan of looking at what we consume and working out what's right for ourselves, right? So keep up with that. But if you want to come in and ask some questions on that, then happily you can get other people's thoughts, other people with PBC, their thoughts about it. Now, the next question, there's not a huge amount of information. I'm finding I'm getting very tired every day. I last about 6 to 7 hours from waking, then need a sleep or lie down in the early afternoon. This is impacting my work a great deal. Any suggestions? I'm going to say before Alan says anything, there's a lot we don't know about you. We don't know what your work is. It could be a very heavy manual job. It could be you're just sitting around all day, both of which will make you tired. We're big fans of movement as medicine, but if you're doing a heavy manual job, I was talking to someone the other day who's cleaning, some days up to 8 hours, and of course she's absolutely exhausted and she hasn't got enough energy to dance. I've got to admire this lady, you know, but we don't have a lot of information. Again, Alan, I'd like your comments, but again, is this not worth mentioning that perhaps more blood tests might be in order as well?
Yes, again, I think Collette is, fatigue is a very common symptom from patients with PBC, but unfortunately, not every patient who has fatigue is related to the PBC. So we need to exclude other things. And again, I just mentioned thyroid is a big one. So I would just make sure that ask your primary care or hepatologist or gastroenterologist to make sure that you check your thyroid test. Check to make sure you're not anemic. And there are other things that go with PBC. Depression is a big one. And I think there's now really good data, and I think Collette has mentioned in the past from the UK about what to do with the fatigue. And unfortunately, I would say unfortunately, the biggest things that we can do to improve fatigue is actually exercise. So there's a study published in their last liver meeting a year ago, and they looked at patients who actually got a phone from physical therapists, and they were encouraged to do an exercise program for 12 weeks. And they compared to someone that will tell, okay, go and exercise and come back. And people who were encouraged to move actually did better from a fatigue perspective. Again, it is very important to understand that, it is life consuming, and it's a very it's a big problem for patients with PBC, but trying to make sure that we rule out everything else is a big thing for them. So I would just basically ask them to get a PCP, rule out some other things, make sure that you're not anemic, make sure that you're TSH. It's checked before we really kind of blame the PBC as a cause of your fatigue.
Yeah, and when he says TSH, he means thyroid.
The thyroid test.
But also too, and we bring this up quite a lot, as you know, Alan, is about diet. Because it's very easy when you're tired to have maybe not as nutritious food, or send in for some food, which seems to be the fashion with the youngsters these days. You just go to your app and it appears at the door. There's a number of things, and also, believe it or not, drinking water. We are a bunch of prunes really in this country, and drinking water 2-3 litres a day is really important. Our lady in the office, Linda has a lovely analogy about this, and she'll say, we can imagine a plant who's not been watered and it's wilted and it's just bent over and dry. And you start feeding that plant with water, and this plant comes to life and wakens up, and that's how I see us human beings. So, there's a few things, but happily, if this person wants to speak with me as well, we can go through. But I think what Alan is saying, some more blood tests and research and maybe a bit of information would be quite helpful. So, our next question: I was told my AMA was not right and LFTs raised. I got diagnosed 2 years ago as PBC from 5 scans, etc. Moving on now, I've got a new consultant who said my AMA is fine. It's fine. I do not have PBC as my blood's improved and then reduced my Urso. Since my itch has been off the scale, very poor response by GP, who said I need to lose a stone, as a consultant thought I had fatty liver disease, even though it was not on any of my scans. So my question, can you have PBC if your AMA is now normal? This is a brilliant question, Alan.
So the question to them is, were they AMA positive to begin with? If the answer is yes, there is no need to check again an AMA. If you have what's called the clinical features of PBC, you have an elevated alk-phos and a positive AMA, there's really no need to follow the titers, no need to follow the antibody testing in the future. So you have PBC, and that's it. So there is a certain amount of patients, very small, say 5% of the patients, who have a negative AMA. And again, based on the guidelines, if they don't have the kind of the elevated alk-phos or histologic findings, so those are the patients who will get a liver biopsy, it's hard to diagnose them with PBC. So I would say, just go back and make sure that the diagnosis was correct. Because again, usually negative AMA PBC patients are males, are getting a liver biopsy from some other reason, and we do find the typical histologic, the liver biopsy features of a PBC. So I would just go back and review what the negative AMA is it is like before we actually commit those patients for ursodiol.
This is quite a tricky one, because this person's now seeing a gastroenterologist who we know not all of them are have the knowledge that hepatologists do, for sure, and it is highly specialised. But this, my blood's improved, so they reduce my Urso. Your Urso, taking your Urso has got absolutely nothing to do with your blood test, it's to do with your weight. Can we talk a little bit about that, please, Alan? How do you describe it?
I mean, that's another important thing, Collette. I think right now we are in the world that obesity is becoming a really bad epidemic around the world. So we have what's called dual liver diseases. So patients can have PBC, but also they can have NASH, like a fatty liver. So Ursodiol is not going to be the treatment for NASH, but as you mentioned, Collette, weight loss is the biggest things that we encourage for patients so they can start, treating their NASH. So I can tell you, we in our clinics, we are seeing this dual diagnosis more than ever. Again, for example, autoimmune hepatitis and NASH, PBC and NASH, PSC and NASH, because there's a big, epidemics in obesity. So I think, as you mentioned, Collette, and I think you actually got to the point, is Urso has nothing to do with kind of getting or improving the liver test. I think the weight loss, that's what it did.
Yeah. So you take your Urso according to your weight. We're about to send everybody charts. We're producing new charts in imperial and metric. I've never moved into metric, by the way, and I think the Americans are still in imperial, but we're doing both. If you're in doubt, go on our website, check the box. And there's one last thing that this person says, which kind of disturbed me, Alan. So itch has been off the scale and a very poor response by GP. This is what sometimes happens, that gastros pass it on to the GP who don't have any specialist knowledge. Now, that's fair enough in itself, but that doesn't mean to say they can't go out and find the knowledge that they need to treat the patient. But the fact they're saying that to lose weight, well, that's as maybe, that's as not. But that GP should still be treating your itch, whether you have it from NASH, PBC, crossover, whatever the condition you have, you are entitled to have your itch treated. And as Alan says, the first line treatment is cholestyramine or Questran or what have you, and there's more medications after that. So I am more than happy to speak with you on the telephone to give you a bit of room so you can go back and challenge your doctor. This is what sometimes happens when you're poorly. You can't always advocate for yourself. And if you're up all night scratching, Alan, I mean, goodness me, you're worn out. So I would happily speak with this person if you care to phone me or any of the team. And so there's various points that have been raised here, but yes, your itch can be treated. And if you had an AMA antibody titer over 40, you've got PBC, and don't reduce your Urso according to your liver function. It's according to your weight. I think 3 really good points in there, Alan. Would you agree with that?
I do. I mean, again, something also that I think you forgot to mention is kind of, as you lose weight or you gain weight, if you do have PBC, it's important to talk to your PCP as I need my Ursodiol adjusted, because as we know from the studies, it's very important to keep it at 1350 milligrams per kilogram per day, because as people gain weight, with COVID, we're at home, the Urso will be not as effective if actually we gain, I'll say 20, 30 pounds and we look at the Urso dose. Well, we've been underdosing for the last couple of months. So again, that's something also to check very, I'll say frequently, or touch base with your GI, PCP to make sure they readjust the dose accordingly to your weight.
Absolutely, 100%. I've just lost 30 pounds, by the way, so I'm coming down with my Urso, but like everybody else. And don't beat yourself up if you've got some COVID weight. These are difficult times that we've never really seen in our lifetime before. So let's all work together to help one another and not, point the finger, So we have recently this person, I keep saying that, I do beg your pardon. This person has recently been given private B12 injections. The GP in my surgery would only prescribe supplements, even though I had been on supplements for approximately 3 years. Serum B12 came back as 201. It measures the amount of B12 in the blood, but not the active B12 that is actually being absorbed. I do believe that I have an absorption problem. My symptoms are all pointing to B12 deficiency, and after 8 weeks of weekly injections, I do feel much better. I did feel that I was slowly dying, and my quality of life was 0. My question is, should PBC patients be screened for B12 and D3 deficiency? And given the B12 injections and D3, especially for fatigue and weakness, that is so common with PBC.
So the answer to that question, so PBC patients, so let's say someone gets diagnosed with PBC, the most common vitamin deficiencies in the PBC are the fat-soluble vitamins. So A, D, E, and K. This is because they're related how we absorb them, because we need the bile system to kind of like help them get absorbed and metabolized so they can function. It's not very common to get B12 deficiency, but that being said, B12 deficiency could be linked to an autoimmune condition. So in that case, if they present with symptoms of B12 deficiency, neuropathies, and we look at the blood counts, we look at the, CBC, we look at their MCV, and if it's elevated and they point out that there is B12 deficiency, we would recommend giving B12. The other thing to actually mention about B12 comes in everything, it's hard to be B12 deficient these days, and the other thing is we cannot overdose, because anything excessive of B12 will pee it out. But I would say if you are having or eating a healthy diet, there is no need to actually get B12, supplementation. But in that case, if it makes them feel better, I would say there is no toxicity from B12, then I would just recommend and continue if that makes them feel better.
Mm-hmm. The vitamin D, I'll stay with the vitamin 12 for a moment. The condition to which Alan refers is, I don't know if it's the same in the States, it's pernicious anemia.
Correct.
My dog has it. Poor thing. My dog gets injections. But I know people have pernicious anemia. It's autoimmune. My cousins have it, and they get one injection every 3 months, and they can feel in the third month, they're kind of like a clock winding down. And they need that injection. So I know you're to this person, you're saying you have the symptoms. It's difficult to know because you haven't actually been diagnosed with pernicious anemia. And the vitamin D thing is an interesting one, because something came out in the BMJ, the British Medical Journal, maybe 2-3 years ago, Alan, about every person, particularly women over the age of 40, in the Northern Hemisphere should take vitamin D, because particularly in Scotland, it's sunny now, but it's very cold out there. We don't get a lot of natural sunlight. So I'm hearing more and more these days that vitamin D is being checked in with your liver function, your liver enzyme test. So it's not a bad thing if you feel that you need it, then do ask. Ask what your doctor thinks. But you're saying you get your vitamin B12 privately, that's fine. I'm hoping it's a medical person doing that. But yeah, check with they can do these blood tests, and you can pick many things up from blood these days, can't you? So but pernicious anemia, I know there's fatigue and everything else, but there's gut problems as well with that. Is that right, Alan?
Correct. But again, there is. So the thing is, PBC as an autoimmune thing has the key for other autoimmune things. The genetic predisposition puts you on the risk for other ones. Again, I would say pernicious anemia is the first one to comes up when someone gets PBC, but I'm sure it is possible. So again, checking the B12, those patients have all their conditions, all their type of symptoms presenting. So, in the levels, they mentioned a level of 200. I really don't have it on top of my head what a normal B12 level is, but if your level is within normal limits, I would say just, keep eating a healthy diet. That should be enough. And one more thing, Collette, that you mentioned about the vitamin D is this is key, or this is important to actually on patients on presentation. So any PBC patient who comes to me as a new diagnosis, I do check the vitamin D. I do a bone mineral density just to make sure they don't have any osteoporosis. So it links in a different ways with the PBC. And actually, you're right. So there's a lot of studies now about vitamin D, and not only PBC, depression. I can even give you like maybe 30 different, good reasons why to take vitamin D. So I think everyone should be taking a vitamin D supplement, like maybe 2,000, IUs per day. But again, vitamin D is a key feature of PBC, and that should be part of everyone seeing a PBC physician. Yeah.
So don't be afraid to ask is really what Alan's alluding to, I think. Okay, so what can you help with, recommend to help my fatigue? Is there anything I can do or buy? Are there any available treatments? I've been hearing some mention of clinical trials happening for PBC. Can you tell me more about these and how I can participate? They're on our website. There's lots of trials going on in the States and here, and there's new ones coming up, fantastic ones. But with regard to your fatigue, again, I think it's important, Alan, that, they have bloods done just to check there's nothing else going on, like menopause or whatever, but, dietary things or anemia, thyroid, etc. But I'm not quite sure what the doctors in America say, but here, as I've alluded to, we do recommend movement medicine. It actually came from Mark Swain in Canada. He's a lovely hepatologist, and I met him many, many, many years ago. And I remember he said, I talk in front of 200 doctors, I tell my patients to exercise, and I knew he was mad. And I wanted to say to him, Alan, don't you understand we're tired and we can't, and how wrong would I have been if I got the opportunity? And he's absolutely, you can buy into more energy. But again, the awful fatigue, I'm sure Alan will talk about what bloods you could maybe look at getting done. But again, be looking at your diet and looking about your daily routines, and I'd happily talk you through things, or the team would on the phone as well.
Yeah, I mean, I think as we mentioned before, ruling out other conditions are big into the differential diagnosis. I think you mentioned celiac disease. PBC comes with celiac disease too. Again, the presentation of celiac disease as fatigue is not very common, but again, I would just, if there's any diet problems or diarrhea, I just suggest checking, a celiac testing.
Yeah.
Unfortunately, most of the clinical trials, Collette, are coming out now are not focusing on fatigue. We have great for disease modification. What does that mean? It means try to treat the alkaline phosphatase, try to treat the stage of fibrosis. We have great clinical trials to treat the pruritus, the itching.
Yes.
But we don't have a really good clinical trial to focus in how we call it quality of life, such as fatigue. Mm-hmm. So, we think that patients with PBC, as they improve their numbers, they will improve their fatigue. But unfortunately, that's not the case. So, again, I will encourage them to exercise, to move. We really rule other things. And, unfortunately, this is as much as we can do in the medical world. But I think you guys, as in the patient side, trying to, be proactive, trying to move, are really key to actually try to improve their symptom, which is, I'm sure it's a pretty big problem.
Yeah, and that doesn't mean necessarily joining a gym. We want you to enjoy what you do, walking with a friend. When I was widowed all those years ago, I just used to walk around, and one day an old friend passes, "Where are you going?" I said, "No, I'm just walking." She said, "I'll give you nowhere. I've got 3 dogs. Come on, you come with me." And I ended up getting a dog. So just nice little things that we can do. To help herself. And you mentioned celiac disease, which I often laugh about because I'm told it's the Celtic people that are with me, which are more prone to celiac disease, which I don't have that, thankfully. But you never forget all these things. If there are any changes in your bowel habit or whatever, mention it. Don't just think, "Oh, well, I don't like to be a nuisance," because you're not a nuisance. You're part of a system. But again, if you want to phone me in the office, do. So this is an interesting we've got here, Alan. My clinician suggested the drugs I was on for IVF treatment could have caused my PBC, but didn't tell me anymore. I'm really confused. Can you please explain how this would work? Well,
I mean, again, I think there is a genetically predisposition for PBC, and unfortunately, none of us know what happened. So again, I would say it's like having the key to a locked door, and we really don't know what triggered that guy to open that door. And unfortunately, we know there are viruses. We know that, for example, exposures to certain, for example, there's some studies about living very close to trash centers in New York City to PBC, but we really don't know. So, if you have a first generation above and beyond, there's a 20% incidence on PBC. So I would say if you do have autoimmune conditions and you do develop, elevated alkaline phosphatase, I think the first thing that should come to our mind will be PBC. But unfortunately, I don't have a really good explanation for that question.
Well, what was it you said? What in New York they think might cause PBC?
So there's there's actually
somewhere.
There's actually a study. They put, a study years and years ago, I would say close to 20 years ago. They looked at PBC and they looked at way they lived in New York City, and they find out that people with PBC live close to all the trash, the big trash centers.
Rubbish.
Yeah, the garbage. Yeah. So, is that coincidental? I don't know. But again, this is going back to, we really don't know what is going to open the key to that, open autoimmunity to those patients. I mean, for example, if you look at the UK, most of the PBC patients in the UK, for example, are in Newcastle, right? That's where all those.
No, that's where they went looking for you. I know David Jones would have that, but we know better.
I know, but they think about, I don't know what's in I don't know what's, there's some like oil thing in Newcastle, correct? Or just.
There's a lot of mining as well.
There's a lot of mining. So I don't know if that's also related to why PBC is so prevalent in those type of the country. So again, there must be some, here it is, you live in this place, you get this open key, and then you're up in the door, and then you develop PBC. So no one really knows the answer to that question, unfortunately.
I've heard gases from mines, David Jones. David Jones loves to hypothesize. He's got some numbers. We chat about it. There's something else I'm going to say, and I can't. I'm forbidden. I've signed a non-disclosure agreement with the fatigue. Something has come along the tracks, and it's exciting, and it's new, and it's European, and it's coming along the tracks. Okay. So I'm pretty excited about it, all right? So just watch the space, everybody. We are speaking with scientists who have got something to say. Okay, now I'm not going to be able to pronounce some of the stuff, Alan, so you bear with me, will you please?
Okay.
So, okay. With FDA approving maralaxabat, yeah?
Yeah.
for cholestatic pruritus in Alagille syndrome, right? Can it be explored again for PBC itch?
So it's called the ileal transporter. So there are two they're coming on. That's one of the medications. The other one is linexabad. I think Cynthia Libby was the leading person studying the drug. So two of those medications are going into what's called phase 3. So they are going to be doing randomized studies. So basically, patients will get either a placebo or the medication. I don't know if they're used for Alagille syndrome, but again,
what is that, Alan?
It's called the ileal inhibitors of the ileal transporter. So basically, what happens is, the way the bile gets metabolized is you have the liver and you have the bile duct, and at the end of the small bowel is called the ileum, and the ileum basically reabsorbs all the bile acids. Right. And there are certain proteins that you can kind of inhibit there to stop reabsorbing the bile acids, and they're being shown to improve pruritus. So again, the phase 2 studies look great. They're only 28 days. I think they're going to longer studies right now. Those two medications they mentioned, I would say they're FDA approved. I would say they are going to a phase 3 trial, and then hopefully they will be approved for itching soon. But their studies, their preliminary studies are very encouraging, and they show very nice, resolution of the itching.
Right. So that's a possible then.
Correct.
Okay, great. Thank you for that. Right. So here's a question for you. Should we avoid food that has high bile content? Now, I can't think of any food that does, but over to you.
I don't either. So the answer is no. I mean, I don't know what would have high bile content.
Yeah. Okay. So this one, and as I say, I don't always get the pronunciations right. I'm an accountant. I'm not a doctor. So forgive me, everybody. A forensic accountant, believe it or not. I've started, and this is SAM in capitals and a small e. Same. Mm-hmm. With my hepatologist approval. I have heard Dr. Jones speak of it as well. It has been amazing. The doctor's thoughts, please.
So those all medications are currently in clinical studies. So the clinical studies of that particular medication, what's also phase 2 is going into phase 3. It looks okay. So I cannot comment it's just going to be a cure. I mean, so far the studies show improvement in the alkaline phosphatase. So I would just talk to that physician. There are clinical trials about that. There will happen soon. But again, I don't have, beyond clinical trials, I don't have any clinical practice data because I don't prescribe that.
Okay. So she's saying it helps with the fatigue, which is quite interesting. So I don't know if that's a one-off, but I think we need to pick Prof. Jones' brains about that one.
Yeah.
Because the fatigue is a big thing. And as you say, there's not a lot of things going on. Right. I have PBC with some osteo and digestive disorders alongside. So take Urso and I prescribe a calcium vitamin D sachet every day, and I'm careful with my diet. A significant problem I have been diagnosed and fits exactly as IBS. Is there any reason why I shouldn't take something like peppermint oil relief tablets? On there's apparently stressful occasions when it flares up. If so, what sort of gap should I leave with Urso? Can you advise a better treatment? Oh, bless.
So again, once you have, the first thing to understand is PBC patients are, they do have the right to have other conditions, and IBS is a big one. IBS is prevalent in the typical, Causa PBC age, females between 40s to 60s. So I would say do as much, you can do anything you need to actually get your IBS under control. There is no need to space out the treatments with the Ursodiol. Sometimes the Ursodiol can be a little bit heavy in the stomach, can cause a little bit of nausea, can cause a little bit of constipation. So what I usually tell my patients, you can take your Ursodiol, for example, before going to bedtime and space it out with the other medications. But I would just suggest whatever the gastroenterologist or PCP wants to do, it's okay from a PBC perspective.
Okay, and good luck with that one as well. I was diagnosed with PBC by a liver biopsy and bloods. Don't get me started. I had quite bad pain at the time in the middle of my ribs and was sick. I vomited bile and it stopped when I started Urso. But this week I have the pain back, almost like a gallstone pain, but I don't have a gallbladder. Is this due to PBC? My liver function has gone down. Is there any other checks I should ask for? I don't know what level my liver is at all. I had a camera down to check my biliary, but it was okay. So before I ask Alan to respond to this, I'm sorry to hear that you're suffering in this way, but I would say to you, you don't know your liver counts. You're entitled to know them. That's the law. So ask for them and ask for the full spectrum. We have an app, a PBC app. Put your liver function, your liver enzyme tests in there. If you're unsure, give us a ring. And then the next thing you have them done, you can pop them in again and you can look at the trends and what's going on. But you are entitled in law to have all that information. And why not? Why not? It's very important we know what's going on with our bodies. So back to this pain of falling on from the liver biopsy. And again, I think there's maybe we could also explain about the fact that the liver can't really hurt. It's what's around the liver, Alan, if that's okay. But this is obviously quite stressful.
It is, and I'm sorry to hear that, that person is experiencing that. But kind of like one of the things with PBC patients experience a lot of pain. They really, when they present, they have either they show because their liver tests are elevated, or they show because they have an itching or they have severe fatigue, but really pain is not really a common symptom from PBC. Again, I would suggest, based on the other things, if pain when you eat and you have diarrhea, make sure that you rule out celiac disease. If you pain when you eat, maybe asking your primary care or your gastroenterologist, do you need an endoscopy to look for an ulcer there? So all those things need to be in place to rule out other things, because I don't think they're related to the PBC, unfortunately.
But she's indicating that came after the biopsy.
Well, so biopsies actually are very painful. Is basically I would describe as stabbing someone in your side, and they're not very fun. You insert a needle into your liver. Usually the pain can stay there for at least a couple of days to a couple of weeks, because what we do is we numb the skin and we can hit some nerves in there, and the pain can last up to your shoulder a little bit longer. But if the pain continues to happen, even despite, pain medications, or it's been a couple of days, I would suggest going back to the primary care, or maybe need some type of imaging to make sure there's not a complication from the liver biopsy itself.
Yeah. And this moves on to our next question. She's had PBC 15 years. Recently, I have been experiencing pain in the liver, but only at night. So if I try to sleep on my right side, the pain is more obvious, but on the back, the pain seemed to disappear. Any thoughts? Now, I hear this quite a lot, Alan.
Yeah, we'll have to kind of examine that person, to be honest with you. But again, I would just kind of mention again that PBC kind of is not very common to have pain as a symptom. So ask your primary care to look for other things, gallbladder pain, there's other things that go with it. So, be evaluated by your PCP or your gastroenterologist, make sure there's no other things happening.
Mm-hmm. I think that's a fair point, because sometimes we think, well, we've got PBC and we don't realize that other things can happen.
Right.
But I think it's important to say, and as I say, I'm not a doctor, that the liver itself actually can't hurt is the sac that surrounds the liver that carries all the nerves and things. You want to, is that, if that's right, can you tell us a bit? Yeah, capsule. Can you tell us a bit about that, Alan, please?
So, as you're right, so the liver is an organ that doesn't actually, you know, when people tell me my liver hurts, really doesn't, your liver doesn't hurt. Basically, is when the capsule, when you get hepatitis, when the liver gets really inflamed, you know, you kind of like pull out the capsule, and that's what hurts. That's what actually causes the discomfort in the area of the liver. So, and that could be caused by a lot of different things. So we can start from stones that can cause from a hepatitis, viral hepatitis, autoimmune hepatitis. So I would say if the pain around the liver, I would just make sure that they get an ultrasound, make sure that they check with their primary care, ask for the liver test, make sure they don't have other things before we just blame it on something like PBC, which is not common presenting with pain.
Mm-hmm. And I think, and I don't want to make MD feel despondent, just sometimes they don't get an answer to these things, do they, Alan? Particularly, yeah.
Yeah, I mean, unfortunately, you know, that goes with some things with PBC. We know that people who are, you know, very uncomfortable with the fatigue, with the itching, unfortunately, they also end up developing depression, you know, and that's a vicious cycle. You know, patients get depressed, they get pains. So again, I'm not blaming on depression. I'm just saying, you know, both patients really need to be seen carefully, need to be evaluated frequently to make sure we ruled out other things before we actually blame like PBC for those conditions.
Mm-hmm. Yeah. And sometimes there's just no answer, but that we can pluck out the air as well.
Right.
But again, you know, if that's sometimes you want to talk over or you want to write in again and we can come back to the doctor with more information, more than happy to do that if that helps. Sometimes just talking about these things helps, though. I'm sure you find that with your patients as well. And somebody who believes you and understands you and acknowledges what you're going through, I think, is a big boost as well. Because many of us weren't believed, weren't diagnosed, treated as hypochondriacs, and then and it's unpleasant. You carry it with you for a long time. So next question, I was diagnosed by biopsy, but I'm AMA negative. Okay, so this small percentage that you alluded to. I'm a partial responder to Urso. Now, I would like to know more about this, Alan, actually. ALK lowering with the addition of a phenofibrate. Should my AME be retested? Well, I think you kind of covered the AMA bit, didn't you, by saying no.
Right.
But I would like to know more. I would like to, if you wouldn't mind telling us what a partial responder is, and I'm not sure I know what a phenofibrate is. If you're happy to explain, please, Alan.
Yeah, so what we in the PBC world today is there's two things that we, you know, when we look at treatment. One is kind of disease modifying medication. So this is basically explaining how the alk phos. So what we know in the PBC world, we are aiming to get the alk phos as low as we can. So what we start, the first therapy that we have available is the Ursodeoxycholic. That's 13 to 15 milligrams per kilogram. And what we do is we give the patients a year. So we follow the blood test. I would say the first year I see them maybe 3 times. And I will say after a year, I look at the alkaline phosphatase. If the alkaline phosphatase is not coming down or is not below a threshold, we call those patients non-responders. And non-responders mean that, you know, their Ursodeoxycholic is not working. And we know in the literature, 60 to 70% of those patients will do not respond to Ursodeoxycholic. Then we go what's called second-line therapies. And in second-line therapies, I think they mentioned the phenofibrate. Phenofibrate is a fibrate, and it's being shown in studies that worked as a second or third-line therapy with patients who do not respond to Ursodeoxycholic. So I would say if that person's alkaline phosphatase is getting better, well, the phenofibrate is doing their job. The other thing to consider in those type of patients is usually I repeat a fiber scan. So you had a biopsy with a negative AMA and you look at the stage of fibrosis. I really look again, I'll say 12 months, 24 months later to make sure that the stage of fibrosis is not getting worse.
So the phenofibrate, is that the same as bezafibrate? So they all...
So there's different. So there's called PPAR, peroxisome agonist, Collette, and there are different types. So there is alpha, gamma, and delta. So for example, in the US, the only fibrate that we have available is the phenofibrate.
I see, right. Okay.
So for example, in the UK, I think bezafibrate is available. So basically that's a PPAR, which basically hits every single receptor. So there's different types of fibrates out there. And there's another one called elafibranor. So there's a third one that's being studied right now. So I would say Elafibranor has really good randomized studies where, they blinded someone to placebo. Bezafibrate, France and Corpechot did a really good amount of studies on that. Fenofibrate has not a lot of randomized studies, but basically because this is the only thing that we have available in the US, this is what we use. Bezafibrate got purchased by Intercept, so hopefully can be used in a kind of like, in conjunction with Ocalivia or obeticholic acid, so we can actually have like a dual therapy.
Yeah, I was going to ask you about that because bezafibrates have been used here for quite a while in the UK based on that small study in France. But I was hoping that our friends across the water could have access to that too. And I'd forgotten about Intercept buying that up. But here's, it's not a case of OCA and, it's either or. And given the prices of drugs, there's choices that are being made there. So I was hoping that our friends across the water will have access to bezafibrates, but you're saying that that's looking reasonable?
Good. Yeah, I would say in the US, we have 2 therapies approved. We have Ursodeoxycholic, and we know that works up to 70%. And the only other FDA-approved medications are obeticholic acid. Right now, obeticholic acid, and then, it's just patient choice. I usually tell patients, this are the side effects. This is, the indications of therapy. But I have a fenofibrate, which is off-label. What means is I will use it without an indication for PBC. I'll warn them about that. I will, kind of check the liver tests. I'll check all those things. But I tell them that there's a pretty good data out there that actually works in patients who are partial responders.
Yeah.
Again, the good thing, there's other PPAR, as you know, Collette, this is exciting times for PBC patients. They're in the next, I would say, hopefully in the next 3 to 5 years, we'll have 10 different new medications approved that will treat all those partial responders. So we will have, hopefully, I would say cure, but at least control the disease without any major issues.
Absolutely. And on top of that, how many new things are coming on board with the itch? I'm talking to a lot of pharma from the States. Chris and I had lots of meetings. Really exciting. And of course, this thing that I'm not allowed to discuss about the fatigue. It's the holy grail, isn't it?
Yep. It's very, very. I agree. It's very exciting, Collette. I think we're getting a lot of new stuff. And again, I know, it's been years since PBC has different options, but I would say, there's clinical trials. So, in the US, I usually talk to patients that try to get in the clinical trial. And then if not, we do kind of, hopefully within the next 2 to 3 years, we will get options for all those patients.
Yeah. The American, I think we know some of the same people. They came over to Edinburgh to speak with Chris and I know they had a meeting with you the following day, and they were talking about the poor uptake and how we can do a bit better here. But we want to share that because we want our friends across the water, wherever they are, to have the same access to clinical trials. And this film that I did yesterday for the States, which is going out in November, talking to researchers, it really is important for people to understand that, this is where the doctor and the patient works together. This is where we make an enormous team. We've got your brains, everything about the technical side of things, and you've got our stories, our experience, our responses, our blood, our biopsies, whatever. Between the two sets, we're going to get there. We're going to get there. I was diagnosed 27 years ago, right? When I was a very young woman, a very, very old woman now. And my liver function, there was no Urso. There was nothing but liver transplant, which scared the living daylights out of me. But and now when I look at the changes, it's just phenomenal. And I'm very excited about it. But we still want the cure, Alan. We must get the cure. This is the holy grail that we're looking for.
Yeah.
A lovely wee question here, okay? Do you have a specialist in Arizona, Phoenix area you could recommend for me for my PBC?
I do.
Oh, you do? Go on then.
I do. So you want me to type? I don't know if in the chat or something.
Can you just say so?
I have to, but there's actually a big PBC person, and I have to look her name, but I know. I know there's another. I have 2 persons that she can see. Dr. Lisa Ola, Blanca Lisa Ola is someone. She actually works at the Mayo Clinic.
Right.
And there's another big PBC specialist there too, who trained under Kate Lindor. I forgot her name too, and I don't know. I knew her name, but I was like, oh, I knew her name now, but I forgot her name currently.
No, that's fine. But training under Kate Lindor, wow,
yeah.
That's absolutely incredible. So I hope you find that helpful. But whoever's out there asking that question, you can actually replay this if you missed anything that Alan has said. So don't worry about it. I'm going to ask you a wee quick question. This is my question because it came up from Bob last week. He was saying that in the States, he's found some of his patients have found primrose oil capsules helpful for the itch. Have you heard of this with your patients?
No, not at all. I don't have any experience with that.
You don't what, sorry?
I don't have any experience with that, so no, okay. I don't have the answer to that question.
Okay, so we've got it live on camera, so maybe it's worth keeping in your head when you've got a patient. Yeah. Right, okay, here we go. I have recently had a spinal MRI and found that I have 5 compression fractures and a few bad discs. Oh, I'm so sorry. I'm so sorry. Went to pain clinic to discuss what I was asked if I had been in a car accident. I said no, but I do have PBC. I had to explain that to her as best I could. Make sure, look, you need to take leaflets with you or download stuff from our website and hand it over. I had to explain as best I could. They've scheduled a spinal epidural. Suggest I have another DEXA scan. Should I forgo the epidural until we see what's causing this? The pain has really stopped my life quite dramatically.
So I'm sorry to hear that, but I would say you can do whatever from a liver standpoint. I really don't know the stage of fibrosis. I mean, I need more details to really give an opinion about what to do with the pain. I'm sorry, but I think they should actually go to the primary care or the pain clinic to manage it. But something very important that comes to that case, Collette, is the kind of like the incidence of osteoporosis. So patients with PBC do get a lot of osteoporosis. Yeah. And, we really underestimate that. So I actually tell my patients when they come in, I do get a bone mineral density and actually follow it every 2 years. Yeah. Because they need to be treated very aggressively, because when they have cholestasis means the alk phos goes up. They don't absorb the fat-soluble vitamins when we first start talking about it, specifically the vitamin D. So vitamin D is a key factor absorbing calcium, and they get severe osteoporosis and they can get fractures like that patient described. So it is very important to screen for that so we can have early interventions with medications that are really good right now working for osteoporosis to offer them. So it is something not to really forget about patients coming to see their PCPs or gastroenterologists, hepatologists. They need to be screened for osteoporosis at all times.
Mm-hmm. Yeah, absolutely. You're asking, whoever asked this question, should I suggest a DEXA scan? So Alan is saying yes. Should I forgo the epidural? That's not really something that we could comment on, Alan. Right. Would you say that's a fair?
I would say I don't know the kind of the extent of the disease or other things, but I would just say, get her pain under control, because that must be really painful. But I would suggest going to the primary care, evaluate her pain, and do whatever they can to get it under control.
The fact that this person's in a pain clinic is really good, because in the pain clinic, they have physiotherapists. You don't call them physiotherapists, you call them something else. And I think that one of the best medical disciplines, somebody said, doctor saves lives and physiotherapists make it worthwhile. This person, that my physiotherapist said that. So this person's in a pain clinic, and it's multidisciplinary we have in this country. Well done that you're there, because with COVID, these things have got long waiting lists. But just see what the team have to say. But Alan said if there is, have the DEXA scan. If there's osteoporosis, osteopenia, there's marvelous treatments out there, and it just might well make the difference. So I think that this is not a one-stop answer. This is a bit of a story, and I would invite that person to come back and to these Thursday sessions. But, we won't be doing them every week in the future, because it's too demanding on doctors. But to come back or write to me, and I can pass them to someone that can help as best they can. I've got one last question for you, Alan. I think you've done very well today. Have you enjoyed all that?
Thank you.
Have you been tested today, Alan? Have you been tested? Anything too hard for you today?
Did I pass my test today?
Oh, I thought you did. Was anything too hard for you?
No. I mean, they're always tough questions, but yes.
How long have you been in hepatology, Alan? Because you look very young.
Thank you. 10 years.
10 years. Wow.
Yes.
Well, you'll have seen it all then. You'll have seen it all.
Thank you. Thank you, Collette.
So this is very simple, this question, dead easy. The titer of AMA or the volume of AMA, does it actually matter how much you have?
The answer is no. A positive AMA is a positive AMA. It's not like, for example, we test for a lot of antibodies when we're doing autoimmune testing. For example, like a few examples, we do the anti-nuclear antibody, the ANA, and the titer does matter there. But for the AMA, it doesn't. And once it's positive, it's hard to say, well, if we test you and it's negative, you don't have PBC. So when patients have a positive AMA, they're either in the, you haven't developed the disease yet, or you will develop the disease in the future. So I would say a positive AMA means you will have PBC. I would say 95% of the times.
No, that's absolutely. We get asked that a lot. Caroline Hill says here on screen, very timely question for me too regarding osteoporosis. Have been recommended to take alendronic acid after recent DEXA scan and a decrease in bone density, but have read it can cause gastric problems. Is there an alternative? Yes,
there are actually better medications right now for Caroline. I mean, there are IV medications, infusions like Prolia, or you get it every 6 months. I forget the other one. There's another one you can get once a year. Again, for example, here in the United States, it depends on what your insurance approves, So, for example, I do start alendronic acid, which is Fosamax, once a week. I know what you're saying is really hard on your stomach, but I would just take it, at least in the morning, 30 minutes standing up, because it can cause what's called pale esophagitis, or can cause a really upset stomach. But this is a really good medication, and this is one of the few medications that we really have good data about actually improving osteoporosis in patients with PBC. So, but yes, there's other options that you can try.
Great. Well, that's the good news. With 4 minutes to spare, we've done it. We've done it. I've really enjoyed this afternoon. It's so enlightening. Well, thank you very much, Collette and Dr. Bond. We've got Mona from the States. I think Mona's in Arizona today. Very informative. Mona is one of our members. Great girl. So thank you for that, Alan. That has been absolutely fantastic. I hope it's not been too onerous for you. Oh, here's Alan. I would say to everybody, keep bringing the questions in. Louisiana, Mona, sorry. These girls, honestly, I drive them mad. And I would say to everybody out there, we've been doing these sessions a long time. It's absolutely wonderful the doctors are giving us their time, particularly because they're working so hard with COVID. I would also actually say these things cost money. We don't ask you for any membership. If you can, go to our website and donate to our cause. I'd be very, very grateful. It's been a great session. They've obviously loved you, I think, because you're younger and handsome. I think you're getting more.
Thank you, Collette.
Anyway, Alan, thank you so much. I'm going to hand over to I'm not going to say young Alan because he's not. To old
Alan.
I didn't say that either.
No, I'd just like to say another very interesting and informative session. And again, thanks very much, Alan, for joining us at it's okay here, 2 o'clock in the afternoon, but what time was it with you there?
It's going to be 10 in the morning.
About 10. Well, thanks very much for giving up your time. It's very, very much appreciated. Yeah, and I'm sure everybody who basically joined us will appreciate it.